stem. Okay, done reading?
Yes.
Right. So if you have read and understood, considering its surgical pathology station, please tell me what type of lesion is this? What is your provisional diagnosis?
So this is a papule, a pearly papule with a central, with rolls in edge, and this is most likely could be a basal cell carcinoma.
Yes, very good. Please tell me, all right, if you would be able to describe the lesion, how would you begin? Begin with the size,
Yes,
approximately.
size, the size, and the
No. Please
color.
tell me how much, what is the size?
Okay, could be less than 1 centimeter.
Yes, less than one. Okay, and then
This is raised, so this is
raised.
a papule. It's not a
Yes,
macule,
yes.
and
And
it looks like the color is there's red discoloration with central ulceration.
central
Looks like on the edges are rolled up.
granulation tissues. These are the granulation tissues. What are these?
Telangiectasia or dilated blood
Yes,
vessels.
very good. So, all right. Would you be able to tell me why this surrounding tissue or surrounding area is red?
I think this is due to dilated blood vessels.
Yes.
An inflammatory process, of course.
Inflammation. Yes. All
Yes.
right. So you've told me what are the differential diagnoses you would consider along with this condition?
I will think of squamous cell carcinoma also
Very good.
with
And
actinic keratosis
very good.
and seborrheic keratosis
Very good. Please
also.
tell me 5 major steps by which this basal cell carcinoma spreads or metastasizes.
Okay, the metastasis is by hematogenous lymphatic invasion to the surrounding structure.
All
And
right. But from pathology's point of view, what happens? There is invasion and infiltration of the surrounding
surrounding structure, yeah.
tissues.
Most
And
basal cell carcinoma is known to be
okay,
very
you told me
invasive.
lymphatic and vascular. Please tell me more. Number 2, release of
Release of PDGF, platelet-derived growth factor, that makes the angiogenesis and to spread and to permeate to the surrounding structure and to the
then what
lymph
happens?
nodes.
There are actually 5 steps of
Embolization
metastasis.
also.
Yes, but embolization is step number 4. Okay, what is the 5th step? All right. If you'll do the biopsy, please tell me, what would you see? What would be the findings in the report?
So, and there will be
So you look for the margins.
yeah, of course, the margin
And
and the depth of
because this is,
invasion.
yes, now you're coming
Yes,
it. And
yes.
palis
And
palisading, ulceration, and
yes, and of course, distal metastasis.
how should a patient with basal cell carcinoma be managed?
And these patients, they are managed with there are medical and surgical approaches and radiotherapy also. So there is surgical, like electrocautery, curating, most microsurgery, and
What medical
cryosurgery.
treatment are you talking about?
Topical.
For basal cell carcinoma, it is always excision biopsy.
Excision.
So yes. Then for surgical, what are the surgical options which are available?
Electrocautery or desiccation.
And
Excision, as you said, and most microsurgery.
right, when you are doing excision, what are the things that you have to keep in your mind?
A safety margin.
Okay, which should be
around 1 centimeter. Safety margin around 5 millimeter around the tumor.
4 millimeter around
Four, yeah.
Around the tumor, and then you have to
Do the
closure
biopsy,
with,
of course.
yes, but closure with the primary flaps, grafts, secondary
Yeah.
intention healing, all these you have to consider. Okay, there could
Yes.
even be cryotherapy. What is cryotherapy?
So this is a cold nitrogen-based therapy that destructs the tumor cells.
What is micrographic surgery, which can be done here?
Most micrographic surgery.
No abbreviations, please. Full say without abbreviation.
MOH. That's the name of the surgeon.
Okay,
That's a serial horizontal section taken from the tumor, and then until you get to a clear margin.
Okay, and then there is radiotherapy, there's tropical, there is
Yes.
Okay, what measures can you suggest which can prevent recurrence of deep margins involvement during reoperation?
At 0.5.
No, there is again that frozen section, that same Mohs microscopic surgery. Okay,
Yes. Yeah.
right. If after excision, patient presents with a defect and you go for a graft, and skin graft has been placed, and after subsequently patient comes to you because of non-healing infection, what might be the cause of this?
The microorganism, you mean? Is
Yes,
Staph
which
aureus is the most
the
common.
most common. Very good. And if you give medication to the patient still does not respond to them, what would you think? What would come in your mind, and how would you go about and manage the patient
I
then?
would think of a resistant microorganism,
Very good.
like methicillin-resistant Staph aureus.
Very good. And then how
In
how
this
should
case,
you manage that?
of course, there are preventive measures and definitive measures I will take.
Yes.
If I will confirm this is a methicillin-resistant MRSA by taking samples from the patient.
Yes.
Then isolating the patient. I will make sure that I will report the incident. Then I will give antibiotic specifically to the patient,
Very good.
like clindamycin, tetracycline, and linezolid.
Okay. Last question. After excision, patient developed regional lymphadenopathy, and you have taken fine needle aspiration of that from
Lymph node.
lymphadenopathy. Yes. Right.
Yeah.
Report comes back to you, right? And it
Okay.
shows Reed Stanberry cells. What would be your diagnosis? How would you interpret that?
So this is most common in Hodgkin's lymphoma. This is a very specific finding in histopathologic finding for
Very good.
Hodgkin's lymphoma.
Excellent. Good. Thank you.
Thank you.